All right, so these are also some assumptions that I think would be helpful for us to just keep in mind, set the intention to see our patients through this lens. Again, patients are doing the best that they can. Patients want to improve even when they're engaging in behaviors that we might conceptualize as unhelpful or unproductive. Any one of us wants a better life and an improved life. And at the same time, it doesn't mean that they're already perfect. So we can always do better, try harder, and be more motivated to change. And that's why DBT also offers a lot of change strategies and skills to help patients cope with their life problems in a more effective way. The fourth one is that patient may not cause all of the problems that trigger these behaviors, that triggers their intent to kill themselves or to engage in self-injurious behaviors, and that they need to solve the problems or the triggers anyway in order to get a better life. And as the clinicians, we are there to support them in doing that. I think this is super relevant. The next bullet point is to keep in mind that suicide is usually the solution, right? And why it's the solution is because the suffering in this life is so unbearable. So they cannot even think about other strategies to get out of the suffering. So our role is to help them think about ways or strategies to reduce the suffering if they can, or to build their psychological flexibility so that they can tolerate or sit in the suffering without doing things that are harming to themselves. Next one, patients cannot fail in DBT. DBT can fail patient, just like, you know, Prozac may not be for everyone, but the patients cannot fail the treatment. It's either the treatment is not a good fit for the patient, or the deliverer of the treatment doesn't do the job to fidelity or with competency. So it's just an approach to see patients in a way that is non-blaming. Like I said, therapists or clinicians who treat the patients will need support through consultation team, supervision, and other ways, training. Questions on this? Okay. All right, so we're going to talk more in the context of DBT intensive program. So what happens when a patient is thinking about engaging in a crisis, suicidal or parasuicidal behaviors, or that they come to you and they say, oh, I just did this, or that they are harming themselves in front of you in sessions or in the inpatient unit type of thing. So what do we need to do as clinicians who are not part of a DBT intensive program? If the patient is in the DBT intensive program, other clinicians should refer the patient to her primary therapist and assisting her to engage with the primary therapist as much as possible if needed. So if you see someone in the outpatient level and then the person said that, you know, oh, I just cut, and then we'll talk more in details about that, or I'm thinking about hurting myself. Your job, the first thing is to keep them safe, obviously, in the moment. And we'll talk in details about how we can keep them safe in the moment. But then the long-term goal is to connect them as quickly as possible to the DBT therapist. If you can, and if you feel comfortable doing it while they're trying to connect with their primary therapist, then our role is to keep them safe and apply some skills in the moment. And typically in DBT, it is the distress tolerance skills. And we're not going to have time to talk more in details about what distress tolerance skills might look like. If we do, we can talk about that. But that's the goal in the interim, to keep them safe. So I want to stop. Any questions in this? Just thinking through your patients in your outpatient panels. What would this look like? Any questions on this?
What do you do in the ED?
If they're already going to the ED, yeah. So if they're already in the ED, I would ask, does your DBT therapist know that you are in the ED right now? Okay, so do they know that the patient goes to the ED? If they say, yep, I did phone coaching, and the result of that phone coaching, my therapist tells me to go to the ED, then, just do what you need to do as an ED clinician there. If they didn't contact their therapist, and the therapist is a DBT therapist and does have phone coaching opportunity for the patient, then I would encourage them to call the therapist. So another principle of DBT is consulting to the patient, right? So we don't want to treat the patient as fallible. For example, we call their therapist ourselves, right? So that's treating them as fallible. That's treating them as if they don't have the skills to interpersonally communicate to their therapist. So what we want to do is, hey, do you think it would be helpful for you to call your therapist right now? Here's the phone. I could step out, but if you want me to stay here, we can have a conference call. But I would really encourage you to call the therapist, your therapist. So that's if the therapist doesn't know. Any questions on that? On why is that? Why do we want to do that? Any guess?
I think it seems like a good way of encouraging the patient to use those skills that theoretically they've been working on in DBT. And from what I remember learning from you before, that's a big component of DBT, is reaching out to the therapist appropriately, to use the therapist as a way to practice those skills. So we're just encouraging that.
Yep. Absolutely. And then I think the next one is to also prevent reinforcing, or to not contribute to negative reinforcement. So sometimes the treatment plan that a patient already builds with a DBT therapist is to not use emergency department until they exhaust all of the skills that they already planned, right? Like all the crisis management, the safety planning. But it might be too difficult for the patients, and they might want to frantically ask for help from other people, right? So it's almost like, oh, I can't talk to my mom. I'm just going to talk to every other person in my life so I get that validation, because the therapist is not reinforcing what they're asking for in the moment. So it would be very important to be consistent, because the therapist hopefully would be the person who knows more functionally why the patient goes to the emergency department. Now, what if the therapist knows, and she's the one, or he's the one who refers the patient and asks the patient to go to the emergency department? Then usually the DBT therapist would say, just follow the recommendations of the ED clinicians, right? So follow the recommendation of the inpatient attending physician.
And you may have just answered my question. I guess the thing that I
wonder or worry about or imagine could happen is someone comes to the emergency department or like to my office in a crisis, they're asking for help. And then if I'm saying, hey, have you connected with your therapist, or how can we get you to talking to your therapist? Like in the moment, that may seem like I'm abandoning them or I'm telling them, hey, I can't help. And so like in the moment, it may make things worse, but overall the long term is under the schedule of the DBT therapy. So like in the long term, it makes things better. Am I thinking about it?
Absolutely. And
Okay.
can we think about as a group ways so that it doesn't feel like you don't care about the patient, right? So because we could feel that way, like, oh, I'm abandoning you, or I'm just gonna, I don't want to deal with you right now because you're in crisis, right? That's our anxiety, which is super valid. How can we deliver it to the patient so it doesn't feel like we don't care or we're abandoning them? Any suggestions or ideas?
Validation.
Right. So we could say, this is a really tough moment. I could see you're angry, you're frustrated, you're hopeless. I mean, I feel it, and I really want to help you go through this crisis right now. And I know, because you're in a DBT program, I know the protocol that has been, shown to be more effective is for us all to collaborate. And then, offering them to call the therapist in the moment too, like during your appointment with them, might make it feel like, it's not just you are leaving them. So we're not like ending therapy or ending sessions and then give it as a homework, but just like, hey, I want to make sure, let's work together so then we can communicate better. So validation of the emotions, usually where I would go to. So again, the recommendation in DBT is what I'm going to mention, but then not all DBT therapists are adherent or using this. But if you have a patient in the ED or inpatient unit who is part of an intensive DBT program, usually they also already have a plan on what they need to do if they decided to go to emergency department or inpatient unit. So I'll share one after this. But when a Herman House patient got admitted to 3 West, he came in with a list of things that he and I already agreed upon, right? So he's not just going to be hospitalized and do nothing, but then he has a list of things that he needs to do in the inpatient unit that he communicates to Dr. Kong and the social worker there in 3 West. So just kind of check in, because sometimes the DBT therapist would already prepare that document. So either the patient needs to practice meditation for 20 minutes in the morning and at night. They need to use distress tolerance skills instead of going to the nurse right away when they want to self-harm. So just kind of check first if they already have those. It might not be written, but they might already actually know. Any of you has had this patient in inpatient unit where they come in with, okay. Wouldn't that be nice? Yeah, so that's kind of the systemic, right? So DBT is also complex, and yeah, not everyone will bring that plan.